Hello. First of all, I would like to thank Dr. Splier and organizing committee members for providing me this opportunity to talk about carbon ion radiotherapies for pelvic sarcomas. This is contents of my talk. First, I would like to introduce what is carbon ion radiotherapy. Then, I will mention about efficacy and safety in the treatment of pelvic non-GYN sarcomas. And finally, I'd like to introduce our clinical experience of GYN sarcoma. Introduction of carbon ion radiotherapy. I would like to introduce the potential advantages of carbon ion beams. First, physical property is better in carbon ion beams. As shown on the left, X-ray dose exponentially decreases with the depth. In carbon ion radiotherapy, however, entrance dose is lower and distal dose immediately drops after target lesion. Thus, carbon ion beams achieve better dose conformity even with single beam. This figure is a comparison of clinical dose distribution among X-ray VMAT, protons, and carbon ions. In carbon ion radiotherapy, peripheral dose gradient is steeper than protons, and low to middle dose volume is lower than X-ray VMAT. So, carbon ion radiotherapy can be less toxic for normal tissue surrounding of the target volume. Second is biological properties. This figure shows a difference of biological properties between low and high LET beams. Yellow spot is energy deposition along with the beam track. In the low LET radiation, sparsely ionization occurs, which resulted in single-strand DNA break. In contrast, in the high linear energy transfer radiation, such as carbon ions, densely ionization induces double-strand DNA breaks, which can cause irreversible cell damage independently of cell cycle phase or oxygenation, more so than lower LET radiation. Such property is advantageous for treating X-ray resistant tumors. This is a picture of treatment room that has both vertical and horizontal beam ports. We also have in-room CT to perform CT-guided patient setup. Our accelerator system is very big and has no gantry. Patients are placed on a couch either with supine or prone position. When we want to use oblique beam, patient couch can be rolled with plus-minus 20 degrees. This slide shows inside of the building. Our facility is 60 meter by 45 meter. We have 3 treatment rooms for patient treatment and 1 for biology and physics research. Carbon ions are produced at ion source and are accelerated up to 70% of the light speed. Then beams are delivered to each treatment room. The color of the machine was designed according to the sunshine, forest, and water in Gunma. Carbon ion radiotherapy is indicated to uterine cervical cancer and used for whole pelvic and local boost radiation. But today I would skip the cervical cancer talk. Efficacy and safety in the treatment of pelvic non-GYN sarcomas. First, I would like to explain treatment planning process. This is sacral chordoma and the tumor is close to the rectum and skin. On the dose distribution, you can see steep dose gradient for sparing the rectum and skin. This slide shows composite dose distribution on the left, and I will show the each beam on the right. You can see the delicate beam arrangement to achieve aiming dose distribution. Skin is one of major organs at risk in particle therapy. In our center, surface dose model is used based on the simulation CT. The picture taken 2 months after treatment shows grade 1 skin reactions, which correlated well with the model. Such model is useful to avoid severe late skin complications. Similarly, we have developed a reference of Lecter DVH curves. For the Lecter dose and volume curves should be below the red line to avoid grade 2 or worse late complications such as bleeding, ulcerations, and perforations. This is a case with sacral chordoma, which is rare and X-ray resistant tumors. Tumor response is usually slow. This is a case with sacral osteosarcoma. The patient was 15 years old at the time of carbon ion radiotherapy. He became a teacher and taught many students as a long-term survivor. This is a case with sacral chondrosarcoma successfully treated with carbon ion radiotherapy. This figure shows overall survival after carbon ion radiotherapy for inoperable bone tumors, which was analyzed from a nationwide retrospective research. The 5-year overall survival was 84% for chordoma, 58% for chondrosarcoma, 45% for osteosarcoma, and 53% for Ewing pinnet tumors. This table shows a comparison of overall survival after X-rays or carbon ion radiotherapy for inoperable bone and soft tissue tumors. The 5-year overall survival in carbon ion radiotherapy was better than X-rays for sacral chordoma, pelvic osteosarcoma, pelvic chondrosarcoma, and retroperitoneal soft tissue sarcoma. Inoperable bone and soft tissue tumors have firstly been covered by the public health insurance in Japan since 2016. These are very impressive cases for any radiation oncologist. Radiotherapy can induce second cancer. In this slide, both of cases had a past history of radiotherapy for pelvic malignancy. Osteosarcoma is well known as X-ray resistant tumors, and surrounding normal tissues received radical dose previously. In spite of such challenging environment, the osteosarcoma arising from the irradiated site was well controlled by carbon ion radiotherapy. Combination of carbon ion radiotherapy with immunotherapy is interesting strategy because carbon ion radiotherapy may cause immunogenic cell death efficiently. This female patient had tumors in the pelvis and the right leg. Carbon ion radiotherapy was provided only to the pelvic tumors, and the patient started immunotherapy immediately after carbon ion radiotherapy. During the immunotherapy, the leg tumor gradually decreased and finally both tumors disappeared. Clinical indication of radical carbon ion radiotherapy for GYN sarcoma is very limited because surgery is a mainstay of the treatment. Here I would introduce a case in which surgery and carbon ion radiotherapies were used radically to treat separate lesions and successfully as a multidisciplinary treatment. A 72-year-old female patient presented lower abdominal pain. The MRI of the pelvis indicated uterine body tumor and left bulky lymph node metastasis. Biopsy from the uterine tumor demonstrated sarcoma. The problem of this case was unresectable lymph node metastasis due to the involvement of the blood vessels. How do you treat this case? When we were consulted about the treatment, we suggested that the uterine tumor will be removed by surgery and that the lymph node metastasis can be treated with carbonyl radiotherapy. However, the surrounding gastrointestinal tract was a problem when administering high dose of the carbonyl beams. Therefore, we requested the insertion of the spacer seed between lymph node tumor and the GI tract at the time of hysterectomy. This picture shows surgical specimen and the light green colored lesion indicated uterine tumor. The uterine tumor was completely resected and pathologically diagnosed as low-grade endometrial stromal sarcoma. Along with the hysterectomy, spacer seed was inserted. On the left, GI tract widely contacted to the lymph node tumor. After insertion of the spacer, GI tract was displaced with a distance of more than 1 cm. Let me explain the bioabsorbable PGA spacer inserted in this case. This spacer seed was originally developed in Japan. It is produced with a surgical suture material made of PGA. The PGA sutures are absorbed by hydrolysis breakdown. On the right, figures shows volume change of the PGA spacer in phase 1 study. Such gradual absorption is good for keeping distance from the GI tract. This slide shows dose distribution of carbonyl radiotherapy. 70.4 gray RBE in 16 fractions for 4 weeks was given. Sufficient dose coverage as well as sparing dose for GI tract was achieved by insertion of the spacer. This figure shows response of tumor and spacer after carbonyl radiotherapy. There is no evidence of disease 2 years after treatment, although the patient developed lymphedema at the left lower leg. What we learned from this case was that surgery alone or carbonyl radiotherapy alone was not curative, but a combination of the two modalities became a curative treatment for the first time. In summary, carbonyl radiotherapy offers superior dose conformity and a higher relative biological effectiveness compared with X-ray beams, which resulted in the favorable tumor response and acceptable toxicities in the treatment of pelvic sarcomas. Carbonyl radiotherapy for GYN sarcoma can be used in the multidisciplinary treatment of unresectable lesion. In particular, safety considerations for the GI tract must be taken into account. The use of spacers is considered in individual cases. I hope to meet you in person in Gunma or India, and we welcome your visit to Gunma. And thank you for your kind attention.